nanometer wavelength, and it breaks the molecular binding. So it breaks the molecules by the excimer laser. But the femtosecond laser is another concept, another theory. It's a photo disruption. It separates, it never ever breaks, it never ever burns the tissue. So it separates to cause disruption, as we're going to understand now, precisely separate tissue at the molecular level. So simply, this photo disruption of high intensity laser light induces a tissue disruption, and there is a layer of narrow tissue. This disruption spots create a tissue incision. Let's understand more what's the idea of this photo disruption. So simply, there is a pulse laser energy which is focused on a precise location inside the cornea, and this location size is 1 micron. Okay, this energy localized at this area will induce something called microplasma. This microplasma is carbon dioxide and water, so it's very simple, and vaporizing approximately 1 micron, as we said before. This carbon dioxide and water, which is present at this area, will be absorbed by time, and an expanding bubble of gas and water is created, separates the corneal lamellae. So this microplasma, the water and the carbon dioxide, separates the tissue. Okay? Once it's separated, it will be absorbed and the tissue will be left separated. Which means that if you leave it for a few hours like this, it will return to normal. Because we just separated the tissue, it didn't cut in the tissue, it did not ablate the tissue. And this is the advantage of SMILE. If you have an aborted case, nothing happens as long as you didn't introduce anything inside the eye. The cornea returns to normal within few hours. Okay? So these two byproducts of photodisruption, the carbon dioxide and water, are absorbed by the mechanism of the endothelial pump. The endothelium works to absorb this carbon dioxide and water and leaving a resection plane. So you have a plane now without anything, an empty plane. This is the idea of the photodisruption. So simply you can induce hundreds and thousands of laser pulses, whether in a horizontal manner or in a vertical manner or any shape that you can create. And this, again, the water and carbon dioxide will be absorbed by the endothelial pump, leaving a resection plane which is created. This is the idea of the femto laser. The pulse could be placed vertically until reaching the corneal surface, even to create a vertical plane. So you can make a flap, you can make a mushroom, you can make anything that you would like to, as like the Photoshop, you can create anything. Simply, the VisuMax, which was the first in the market, and now there are a lot of other machines that took the same concept from J&J and from Zimmer. I don't have any financial interest, and now I'm not a consultant of Zeiss by this time, so I don't have any financial interest. So the VisuMax was the first to have this technology, and it was very precise with very high energy, and by time the repetition rate was started with 200 kilohertz, and then 500 kilohertz, which is the most popular now in the market, and the newest is 800 kilohertz. This 800 kilohertz, its advantage, it doesn't take more than 9 seconds to do the whole procedure of SMILE. Now we are taking about 32 seconds, or between 25 and 32 seconds, depending on the amount of energy that you are giving or putting in the machine. But the new machine, the 800 kilohertz, just takes 7 to 10 seconds to finish the whole surgery. And this overcomes the problems, the original problems of SMILE is the long time, the decentration, the cyclotorsion, all of this had been solved in the new machine, or they were criticized in the old machine, and they had been solved in the new machine. And as I just told you, the Zimmer and the Johnson & Johnson, they have two new technologies in the market now, and they are approved, and they are doing also the same concept. So the advantage, as we said, when we did the comparison of this study or this presentation, it was just with the 15 kilohertz and the 30. Now we are using the 500. So see how is the surface smooth, as you see here, not like the blade or the low energy. So the higher the energy, the more smooth the surface that you find, and the more smooth the surface, the less the rehabilitation time. Simply, it creates even if you are going to talk about the flaps before the idea of smile, it creates like a manhole cover. So when you remove the flap, it comes back as if you are putting the cover. So you don't, the problem of decentration or microstriae or macrostriae is nearly not present in the femto laser. And again, the side cuts, as I said, you can make it on 100 degree, 90, 80, which are the most common is the 100 degree, and even the keratoplasty for the bulk, we can make it on the mushroom shaped or whatever you want. So what can we do? We can do very thin flap and or high flap thickness reproducibility, and of course it is fixed with a certain amount of energy. So you can all of the time you are sure 100% that the thickness of your flap is 100 micron or whatever you want, not like the other microkeratomes, which is not predictable. You predict it's 100 and maybe 150 as measured now by the OCT. Yes, we are talking about the smile, but I'm stressing about the flap in this point just for one thing. I know that most of you are doing femtoflaps. You have to treat the femtoflaps with the hyperopes different from myopes, or the hyperopes, the femtoflap differs from the microkeratom flap. The microkeratom flap is a meniscus flap. So for the hyperopes, you are giving the laser, which is more at the periphery. So you are putting, instead of +3.5. Why? Because much of the laser had been lost at the periphery because it needs deeper power or it needs a longer time to reach the periphery because it is a meniscus flap. If you are doing hyperopic LASIK with a femtoflap, no. Give the exact amount of hyperopic, not more. Why? Because it's a uniplanar flap. So it's not a meniscus, so the depth at the periphery is equal like the depth in the center. This is a very important point because if it is deeper at the periphery, like the meniscus flap, you have to give more laser. But in the femto, put the +3 as it is, not +3.5. So don't increase the power in the hyperopia as you are doing for the microkeratom flap because, as you see here, this is the meniscus flap with deep periphery, but here is the uniplanar flap. And this is the difference, which is very important for the hypermetropic LASIK. So the OBLs are a reaction which appears from the microplasma, and usually it disappears within a few minutes when you transport the patient from one machine to the other, if you are doing the femto flap, but usually it does not appear in the smile. Low corneal suction is another very important point because in the high myopes with the large globe, the incidence of posterior vitreous detachment is higher with the microkeratom more definitely than the smile procedure because or the femto in general, because the pressure you are inducing is not more than 30 millimeter mercury, while in the microkeratom it reaches up to 60 millimeter mercury, and that's why the incidence of PVD is more. That's why the patients of high myopic LASIK usually say after the surgery, I felt there is some floaters more in front of me. You tell him because of the PVD. Definitely the amount, the loss of vision there is no loss of vision for the femto, and the suction lasts, as we said, between 20 and 30 seconds depending on the flap diameter and on the smile. So the femto flap, as we said, it has a lot of advantages, and I know most of us are turning now from the microkeratom to the femto flap, but because of the economic reason, maybe you are doing the microkeratom or the SBK. And again, if you have a good centralization and proper suction, and now we're doing the suction before total touch of the cone to the cornea. When it is 80 or 90%, just induce the suction. This will give you better comfort, better centralization. As you see here, the flap starts from the periphery to the center. And if you're going to do the flap, you will have the edges at the periphery, and here the flap had been formed. And this is the end of the surgery. Okay? And then you can remove the flap. And this is the femto flap. Let's go to what we passed with is the flex. Now, nobody's doing flex now, but the idea came is as long as you are removing a flap, we can do a lenticule and then remove the lenticule with the same idea. And this is the start of the flex. هحتاج دقيقة، أنا في تو مش هيتكلموا فعشان كده مريح في البرزنتيشن. دي أو نص بالظبط. كويس. It's like the smile. Right? But instead of having small incision, the idea came that you have a complete flap like the regular flap, and then you remove the flap and you'll find the lenticule behind and remove the lenticule. Of course, this is a very old surgery, and that's it. So and return the flap again. So it's like the smile exactly, but with a large flap. This was the flex or the start of the smile. Then they said, why to do all this large flap? It's preferable to do just small incision and get the lenticule out. And this is the idea of the smile now. This is the case that we are doing regularly now for myopes from -3 and up, or even less, with less astigmatism, starting from the periphery to the center, creating the side cuts, and then the lenticule. Simply identify, as my colleague is going to describe the techniques of smile now, and from the corridor, you stick to the inferior surface of the cornea above the lenticule, and then go behind the lenticule, separate the lenticule from the stroma, and crumple to the side, and then remove it, and that's it. And this is the surgery finished. No flap, there is no striae, no pain. The rehabilitation is faster. Thank you so much.